tendons. And when they are around the tendons, they're actually called tendon sheaths. So tendons are the connective tissue that connect muscle to bone, and sometimes they run through structures, and you want them to be able to slide, right? Because the tendons actually have to be able to stretch a little bit, and then they have to be able to recoil. So they have a little bit of movement in them as well as the movement of the whole muscle. So if we look at an example of where this is important, in the shoulder we have, oops, my picture's of my shoulder. Dang it. In the shoulder, and I just looked at this too. Maybe it's right there. Oh, there we go. In the shoulder, we see that there are lots of different bursa. So there's one that is underneath the acromial process, and so that is called the subacromial bursa. Okay. So that is the point of the shoulder. So that is the where the clavicle articulates with. And then you'll also see that there is a tendon that runs up, and you'll remember that it runs in a groove. And does anybody remember what is the groove called on the humerus where the tendon runs? So it's something tubercular. So we have the intertubercular groove, right? And so that tendon needs to run up, and it needs to be able to move, stretch and move, and without any friction. And so we have the tendon sheath, okay? So sometimes these can become inflamed and is called bursitis. So you might hear people complaining about their bursitis. And this is just inflammation of the bursa. And compared to other joint injuries, this is relatively minor, right? You'd much rather have bursitis in your shoulder than a torn ligament, right? Or a torn tendon, torn rotator cuff muscle. So bursitis is generally better, and they generally will take care of themselves. Although in some instances, the bursa can get quite large. And so there is actually one in your knee that creates really interesting symptoms. And so if we look at the knee joint, there is a subpatellar or suprapatellar bursa right here. And then there's also bursa that are on top of the patella. And so if you're on your knees a lot, that can actually become inflamed. And so you get these crazy things and people are like, oh my God, what happened to your knee? But it's not that serious, right? That's just where the fluid is filling up that bursa. So sometimes I guess they would go in and drain that, or sometimes it would just repair itself. Has anybody ever had that happen to them, bursitis in the knee? No.
Is that what they call runner's knee?
I don't know. That's a good question. I'm not sure. Oh, runner's knee could be, I know somebody who has runner's knee and he's actually lacking synovial fluid. So he's done so much damage to his joint from running that he isn't producing enough synovial fluid. And so it's the lack of the synovial fluid in the joint cavity that's the problem. So, but I've known people that have gone running and then they came back and this is what they get. So they can get this from running too. Okay, so those are the bursa. So synovial joints and bursa both have synovial membranes. Okay, so in your book, there are tables, which are kind of nice because they summarize the different types of joints that you have in your body. So for example, if we look at the skull, that would include fibrous, and they're also called sutures, and they're synarthrotic and they have no movement. If you look at the one between the atlas and the occipital, this is a synovial joint. So remember how I told you that most joints are synovial. So this is an example of a synovial joint, and it is diarthrotic, which means it's pretty movable, and it is biaxial, which means that it has two planes of movement. So the thing that I want to point out is that we have some joints that are uniaxial. So this is under, uniaxial. So this is one plane of movement. Biaxial means that there are two planes of movement. Oops, planes of movement. And then we have multiaxial, which means that there are many planes of movement. Okay. So if we look at this just as an example, here we can see that there is diarthrotic and this biaxial. So we're going to talk about what flexion here is. So we have a little bit of flexion in that joint between the atlas and your back of your skull. And then we have some extension. And then we have a little bit of lateral flexion. So this is actually moving off to the side. So notice I have two planes of movement. I can move forward and backwards, and I can move side to side. And so that's the idea of biaxial. Okay. If we look at some other examples of this, for example, the elbow joint. So the elbow joint right here. So the elbow joint is diarthrotic. It is uniaxillary. So if we look at this, our elbow should only move in this plane of movement. It should not move side to side. So you're asking, well, how come we can rotate the elbow like that? That is not the actual elbow joint per se, but it is the joints between the radius and the ulna so that they can cross, right? So we can have our hand pointed up and we can have our hand pointed down. And so that is, this would be one plane of movement. So your elbow is uniaxillary. Okay. Multiaxial would be like the shoulder, which I can move in many different planes. I can actually move it in a circle, which is called circumduction. Okay. So when you're doing your essay questions for the joints, you might want to look in this particular table, these particular tables, if you wanted to do the elbow joint, for example, as part of your essay question. Okay. So let's talk about types of movement. So we have flexion, for example, and this is where you're decreasing the angle between two bones. So I can have flexion at the elbow where I draw my lower arm up to meet my upper arm, and then notice that that is decreasing, right? Decreasing the angle between the two bones. Now there is a kind of a weird example of flexion in our feet. So in the feet, we have dorsiflexion. Okay, so if I look at this word, dorsi means the dorsal surface. So that's the top of my foot, right? So top of foot. So the angle that I'm looking at is with the shin, right? So top of foot moves toward, toward shin, right? So that would be like this. Right? So I move my top of my foot towards my shin. Okay. We also have at the ankle, we have plantar flexion. Okay. So plantar is the bottom of your foot. This is where you plant your foot onto the ground, right? So that is where the bottom of the foot, bottom, moves toward the calf. Okay, so this would be like pointing your foot, right? So if I'm pointing my foot, I'm decreasing the angle between my bottom of my foot and my calf. Okay, so in the ankle, so I'll put ankle joint, we don't have a flex or an extension. So we don't have the opposite of flexion. They're both flexion. It's just that they're dorsiflexion or plantar flexion. Okay. So we also have extension. And this is where we increase the angle between two bones. Okay. So if my head is slightly bent like this, when I lift it up and I lift my chin up, that would be extension. So I'm lifting my chin up, so decreasing the angle between my jaw and my sternum. Okay. However, we also oftentimes talk about hyperextension. So hyperextension is where you decrease the, or you increase the angle beyond 180 degrees. Okay, so you increase beyond 180 degrees, right? So if this is a straight line, if I'm going to hyperextend my neck, I'm going to bring it back like this. Okay. If I'm going to hyperextend my spine, I do a back bend. So that would be hyperextension of the spine. Extension of the spine is just standing straight up. So they talk a lot about how not to hyperextend your joints, like how not to lock your knees and hyperextend, or how not to hyperextend your elbows.
Are we still talking about the foot ankle area?
No.
Okay, you're just saying.
So I'm talking about like leaning your head back. That's actually hyperextension because I'm increasing the angle. So actually, a good way to remember this, what is the difference between extension and flexion? Flexion is fetal position. So I'll put fetal position here. Because when you are in fetal position, your torso, your spine is flexed, your elbows are flexed, your wrists are flexed, sometimes even your fingers are flexed, right? And so you're kind of curled in on yourself. So that is flexion. And then when we extend and we become nice and long and upright, that would be extension. We also have movements that are called adduction and abduction. So think you put them together, right? So I adduct my fingers and I bring them together, right? If I abduct them, I pull them apart, right? So adduction is bringing bones together. Or bringing bones, we'll put towards midline, for example. And this would be bringing bones away from midline. So this occurs in the fingers, for example, right? Just like I showed you, ab, right? The finger joints between the phalanges and your metacarpals can move in two directions. So I can flex this joint, so that would be flexion. This would be extension. This is abduction, so things like kidnap. And then this is adduction. So that would be biaxial joints, right? It can move in two different planes of movement. This can also be arms, and it can be legs, right? So if I bring my arms out to my sides like this, what am I doing? Abduct. I'm abducting my arms. And that's your big muscle right here, your big deltoid muscle, draws the humerus up. And if I bring them together here, then that's adducting. And the same thing with the legs. If I take them apart, that's abduction. If I bring them together, that's abduction. I forgot to mention up here on the flexion is that we can have lateral flexion. So this is side movement or side bending. Let's put side bending. Okay. So I have lateral flexion in my neck. I can bend side to side. And I also have lateral flexion in my spine. So I'm decreasing the angle between my joints, right, as I flex, as I do the side bends. So this would be in the spine, for example. We also have protraction and retraction. And this is specifically in the jaw, for example. So I can stick my lower jaw out. So I can move that jaw out. So in the jaw joint, I can protract it, and then I can bring my jaw in, and that would be retraction. So drawing the lower jaw in would be retraction, pushing it out would be protraction. Okay. We also have a movement which is called supination and pronation. And this is between the radius and the ulna. So this would be radius. This would be in the elbow joint. Okay. So the way to remember this is that when I have my palm up or palm out, so this is anatomical position. So you always want to make sure that when you're talking about your bones, like my thumb is lateral compared to my pinky because I'm always standing in this position. So whenever anatomical position isn't from here, it's from here. And the reason why it's from here is that then you can see the bones, they're in a straight line. When I go like that, they cross. And so it's more confusing. So this is why this is anatomical position. So this is supination, palm up or palm out. This is supination. So just remember, you're carrying a bowl of soup. Okay. When I pronate my hands, I turn them palms down or palms down. So that would be pronation. We also have elevation. Oops, elevation. And depression. So to elevate would be to bring it superior, right? So to move it up or superior. Depression is down or inferior. Right, so obviously I can elevate and depress my jaw. So I can open my mouth when I depress my mandible, or I can close my mouth when I elevate my mandible. But you can also do this as the shoulders. So the shoulders, I can elevate my shoulders and I can depress my shoulders. Okay. So elevate and oops, I already wrote that, sorry. Shoulders and jaw. Okay. And then there's one more called opposition. And this is specifically for the thumb. This is in my thumb. Okay. So I can bring my thumb and oppose it with my index finger, my middle finger, my ring finger, and my pinky finger. So all of those would be opposition. So my thumb is opposing the other fingers on my hand. I can also draw it down to the palm. Okay. So that is what is called opposition. Right. So think opposable thumb, think opposition. Okay, so a little quiz here. So what is my hip here? Hip joint would be, what am I doing to my hip joint? Extending might even be hyperextension, right? What am I doing at my knee joint? Flexing, right? So flexing at the knee joint. What am I doing with my foot? dorsiflexion, right? So hyperextension, flexion, dorsiflexion, right? So in order to use these words, you have to describe what joint you are moving, right? So what is the joint? So at the knee versus the hip. So if you're looking at a person's body, you want to ask, like, if I'm talking about here, you'd say, oh, well, that is, or here, that is abduction of the arms, flexion of the elbows, adduction of the fingers. Okay, at the finger metacarpal joints, phalangeal metacarpal joints. Okay, so in your book, there is a really good review of this, right? So you can see the movements, angular movements, flexion, extension, hyperextension. So I might show a person, oh, I forgot one. So I might show a person and I might show like this lifting, and you would need to know, if I drew this diagram on the midterm, you would need to know that that is abduction versus adduction. So I forgot one for the arm, for the shoulder specifically. So the shoulder also has circumduction. The shoulder and the hip. So they can go in a circle, right? So I can circumduct my shoulder, but I can also circumduct my hip. So those are the most movable joints in your body because they would be multi-axial, many, many different planes. Oh, I also forgot rotation. Sorry. This is why I put these up here. Rotation. Okay. So I talked about flexion from side to side, but we also have the ability to rotate. So the neck, for example. So this is the neck. But we also have the ability to rotate the femur at the hip joint. Right? So if I turn my toes in, then that would be medial rotation. Right? If I turn my toes out, that would be lateral. So I'm rotating at the hip joint, I'm rotating the femur. So toes in and toes out. So here they show toes out would be the lateral rotation, medial rotation would be toes in. Okay, so this is toes out, toes in. We could do that also with our arm. So I could, if I'm standing like this, I could roll my arm like this, right? And I can bring it back like that. So if I'm gonna laterally rotate, I'm gonna rotate my arm to the back, okay, out to the side. Okay. We also have one more that I forgot to mention, which was this one. So this is in the foot. So inversion would be bringing the bottom of the foot to the inside. So medial. So like if you tend to wear your shoes like I do, which is like I walk on the outside of my feet, I'm actually kind of inverting, right? So I'm kind of pushing my soles of my feet to the inside. And then if you're like walk, I don't know if you could walk this like this, but that would be eversion, right? So where you're standing on the inside of your arches. Okay. So eversion is bottom of foot to the outside. Okay. Okay, so we're going to talk about the different types of synovial joints. And these have to do with generally the shapes of the articulating surface. So for example, we can have plane joints. So think about that the articulating surfaces are flat. So this would include like the wrist. So those bones, your carpal bones, they can kind of move because you can kind of you can move your wrist back and forth, and they actually have kind of a gliding motion. So we have the gliding motion. We also have the facet joints in the spine. So remember facets. So the vertebrae articulate with one another, superiorly and inferiorly. We also have the hinge joints. So this means that they are only moving in one general uniaxial movement. And so the hinge joint would be like, for example, the elbow. And so we're going to look at the elbow in more detail. I also think that the knee is primarily a hinge joint as well. So we generally don't have, or we don't want too much side-to-side movement in the knee. So the knee is best when the knee and the ankle are in alignment. So those are hinge joints. We also have ball and socket joints. So what are the two main ball and socket joints? Shoulder and the hip. Okay, so those are the joints, the shoulder joint and the hip joint. We also have what are called condylar joints. And this is where the bones have a condyle on them. So they kind of meet like this. So the two condyles fit together. And so a good example of this is in between your metacarpals on your hand and your phalanges. So this is a good example is metacarpals and phalanges. Okay. We also have pivot joints. So these allow for rotational movement around an axis. So for example, when we look at C1, C2, C2 has that dens, that tooth-like structure that sits up, and that allows for most of the rotation of the head. So this would be like between C1 and C2, or this is the atlas and the axis. And then we have what is called a saddle joint. So we have a bone that sits in a depression like this, like a saddle. And the big one that they talk about in our body is the thumb. So this is the thumb joint. Right, so this was what allows the thumb so much mobility, right? It's between the thumb, the phalanges of the thumb, and the metacarpals. Okay, so in your book, they have some pictures of these, right? So if I showed you a picture, you would know two flat surfaces, you know that is a plane joint. You know if it sits, and the elbow joint is the example, that it is a hinge joint. This is the pivot joint, and so we have the atlas and the axis. We also have the radius and the ulna. So this is the ulna bone, and there's the sleeve of connective tissue that allows for the rotation of that bone, of the radius. Okay. And then we have condylar joints. And then between the metacarpals and the phalanges of the carpometacarpal, sorry, the carpal I guess it is the carpal bones and the metacarpal bones. That is the saddle joint. And then we have the ball and socket joints, which allow for that multi-axial movement. Okay. So the first joint that we're going to talk about, and I have a little handout. So we're going to review some of the skeletal anatomy while talking about the joints. Okay, so what is this joint called? In your diagram?
Temporomandibular?
Yes, TMJ, right? That's the temporomandibular joint, right? So we know that this here is the temporal fossa. And we know that this here is the mandibular condyle. There is also a piece of cartilage. So we have a pad of cartilage here, which is called an articular disc. So that is kind of similar to the menisci of the knee, is that articular disc. And so I'm just going to show you a short little video that talks about the movement of the jaw in this particular joint and what happens when people have TMJ in particular, where their temporomandibular joint can get stuck, right? And it can also lead to a lot of pain because, and it can also lead to difficulty opening and closing your mouth and that clicking sound when you open and close your mouth.
The temporomandibular joint, the TMJ, is the joint between the lower jawbone, the mandible, and the temporal bone of the skull. The TMJ is responsible for jaw movement and is the most used joint in the body. The TMJ is essentially the articulation between the condyle of the mandible and the mandibular fossa, a socket in the temporal bone. The unique feature of the TMJ is the articular disc, a flexible and elastic cartilage that serves as a cushion between the two bone surfaces. The disc lacks nerve endings and blood vessels in its center, and therefore is insensitive to pain. Anteriorly, it attaches to lateral pterygoid muscle, a muscle of chewing. Posteriorly, it continues as retrodiscal tissue, fully supplied with blood vessels and nerves. The mandible is the only bone that moves when the mouth opens. The first 20 millimeters opening involves only a rotational movement of the condyle within the socket. For the mouth to open wider, the condyle and the disc have to move out of the socket, forward and down the articular eminence, a convex bone surface located anteriorly to the socket. This movement is called translation. The most common disorder of the TMJ is disc displacement, and in most of the cases, the disc is dislocated anteriorly. As the disc moves forward, the retrodiscal tissue is pulled in between the two bones. This can be very painful as this tissue is fully vascular and innervated, unlike the disc. The forward dislocated disc forms an obstacle for the condyle movement when the mouth is opening. In order to fully open the jaw, the condyle has to jump over the back ends of the disc and onto its center. This produces a clicking or popping sound. Upon closing, The condyle slides back out of the disc, hence another click or pop. This condition is called disc displacement with reduction. In later stages of disc dislocation, the condyle stays behind the disc all the time, unable to get back onto the disc. The clicking sound disappears, but mouth opening is limited. This is usually the most symptomatic stage. The jaw is said to be locked as it is unable to open wide. At this stage, the condition is called disc displacement without reduction. Fortunately, in majority of the cases, the condition resolves by itself after some time. This is thanks to a process called natural adaptation of the retrodiscal tissue, which after a while becomes scar tissue and can functionally replace the disc. In fact, it becomes so similar to the disc that it is called a pseudodisc.
Okay, I laugh because I can't help but open my mouth, you know, and it's like really loud clicking, right? Does anybody else have that problem? Yeah. So it used to be painful, now it's not so much.
My high school math teacher can lock his jaw open. Like he can just pop it out kind of.
Yeah, so it's kind of interesting because we all, you know, you think if they talk about snakes that have to unlock their jaw, right? But we actually all have to unlock our jaw. So you'll notice that there's a, if you open your mouth just a little bit and then open it a little bit more, there's an actual place and time when you can feel that actually becoming a little bit dislocated. Okay. So luckily it seems to reduce in pain as you get older. Okay, so let's look at the shoulder joint. Okay, so I mentioned before that this is the glenoid fossa, or it is or cavity. So when you're describing it, it would be either one of those. So that is on the bone, but we also have this structure which is called the glenoid labrum. So this is the glenoid labrum. And this is connective tissue that increases the depth of the articulation. So it can be a little bit misleading when you just look at the structure of the bones. You're like, wow, that doesn't even sit in there very deep. You can imagine how easy it is to dislocate the shoulder. But this connective tissue actually creates a lip where the head can actually sit more deeply into that. And we can see it in the dissection of the cadaver. So I think there's actually a picture of it in the cadaver in your book. But so notice here that this is the glenoid labrum right there. And so that just increases the depth of the articulation. So remember that this is a relatively shallow articulation compared to our hip joint, for example. Okay. And then here we have the head of the humerus. Here we have the biceps brachii tendon. Here's the tendon sheath. And we also notice that there are some other ligaments and tendons that are up here that you don't need to know. Okay. So in order to stabilize this particular joint, we have what are called the rotator cuff muscles. You're not going to learn these this term, but there's 4 muscles. And they are noted for because they have tendons that extend over the shoulder. So we say the tendons extend over the shoulder and help to stabilize the joint. Okay, and so that's why when you have a rotator cuff injury, your shoulder becomes really weak because you might not be able to even lift anything over your head because the joint is unstable at that point, right? So the head can dislocate easily if the rotator cuff muscles are not strong. And so just like with the leg muscles, strengthening the rotator cuff muscles actually aids in keeping the shoulder healthy and stable so that it's less likely to become injured. Okay, so this just shows, no, that doesn't actually show the tendons. Actually, it does. So this is the tendon. So this is an example of some of the tendons of the rotator cuff muscle. Here it is. Okay, so this just shows some of the tendons and the ligaments that cross the shoulder. And so kind of to hold the head of the humerus into that glenoid cavity. The next joint is the elbow joint. So what bone do you think this bone is? It has a U-shaped structure. It is the ulna. Okay. What is this notch called? Does anybody remember? Nope. This is called the trochlear notch. So the trochlear notch is on the ulna. And this just shows one side. So this would be like on the inside. So if I'm like holding my elbow up, it would be the inside of the elbow, right? So it's not showing the outside, which would be the radius. And so this bone is what bone? And so what is this structure, you think, that sits in the trochlear notch? It would be the trochlea. Okay. What muscle do you think this is on the front side of the forearm? Biceps. Right? We say brachia because there's actually a biceps femoris in the lower leg. This would be my triceps. And both of those have tendons that extend over the joint. Right? So this is a tendon, a tendon. Right? What is not shown here is the other bone, which would be the radius, and the radius articulates with the capitulum. So the radial head articulates with the capitulum of the humerus. Okay. And again, there's all sorts of other structures, the ligaments that would help to stabilize this bone. Okay, so that's not all of them. So there's some other diagrams and pictures in your book. Okay, so this would be the hip joint. And actually, I didn't give you a picture of the hip joint. And we're going to be looking at the hip joint this week in lab. So I'm going to move on. Okay. Actually, I wanted to show an animation. So we'll talk about the hip joint, actually. Running out of time here. But okay, so this is my hip joint. Okay. So the head of the femur sits in what structure? Acetabulum. So this would be articulates with the acetabulum. So remember that we already talked about the labrum in the shoulder. This also has a labrum. So this actually makes the articulating surface even deeper. We also have ligaments, and one of the interesting one is the ligament that connects the head of the femur right to the bony pelvis. And so we're going to look at that structure on the femur, that bone. It's the fovea capitis, which is kind of like in the middle. It's a little indentation in the middle of the femur. Okay. So I'm going to show you an animation now of a hip replacement. And you can actually go online and they have like hour-long surgeries if you want to actually see the real thing, right? So they have all sorts of animations of surgeries online. And we're just going to watch what they do for the hip replacement.
To begin the surgery, your physician will make an incision in the skin over your hip joint, cutting through the skin, soft tissue, and muscle to access the hip. Once the hip is reached, the ball is dislocated from the socket and removed from the end of the femur with a saw. The socket, or acetabulum, is exposed. After measuring the size of the socket to guide accurate selection, the appropriate reamer, a cheese grater type device, is used to create a perfect hemispherical bone socket that matches the external shape of the acetabular cup. The cup is carefully positioned in the bony socket. This cup is held in place using a number of methods, depending upon surgeon preference and your bone quality. These methods may include bone cement to hold the cup in place. Most cups are designed to allow bone to grow into the metal surface to hold the cup in place. These cups have a roughened or specially prepared surface, which is designed to allow ingrowth of bone into the metal itself. This type of fixation may be augmented by screws to help fix the cup in place while bone growth takes place. The inside of the femur, or thigh bone, is then cleared with various types of devices, and a prosthesis is placed into the femur. A trial ball is placed on the top of the femoral stem, and a plastic insert is placed into the cup. The hip joint is then articulated by placing the ball in the artificial socket. The hip is evaluated for the type and amount of motion it has and the stability of the joint. That is, the inability of the ball to dislocate from the socket easily. Once the appropriate combination has been found, the ball is then placed onto the femoral stem and the final insert is placed into the cup. The leg is evaluated again for stability and mobility and leg length equality. Throughout the operation, numerous measurements and operative considerations are taken to equalize leg lengths. However, the primary goal is to achieve a stable, non-dislocating hip. Prior to final assembly of the total hip, leg lengths are again evaluated. The new implants will replicate your hip joint. Your physician will rinse out debris from the hip joint with sterile fluid and then close the wound in layers with stitches and/or staples. A plastic drain may be placed in your hip and removed later. The purpose of the drain is to remove blood from the inside of the joint and tissues that might accumulate in the area after surgery. When you awaken from surgery, you will be in the recovery room.
Okay. Any questions about that? Total hip replacement. It's pretty amazing what we can do. Okay. Imagine before we had that and how painful life would have been before we have the ability to fix joints. Okay, so the last thing we're going to talk about today is the knee. So you have your diagrams of the knee joint. So that is on the back of the paper, and there's one that's on the side, and then there's one that's facing the front. Okay, so we actually have two joints here. So we have the joint between the femur and the patella. So this is called the femoral patellar joint. Femoral, I think there's an O in there. Patellar joints. Right? And then there is the femoral tibial joint. So notice that the femur does not articulate with the fibia. The fibia is the outer bone. It is the skinny bone on the outside of the leg, and it does not articulate with the femur. It articulates with the top of the tibia. Okay, so looking at the side view, we can see that there is articular cartilage on both of those. And so when you look at the femur and the tibia, you'll notice that they kind of sit together, the condyles sit together, but that articular cartilage helps to bring those bones together more fully. And they also sit within the menisci. So this is a menisci. So this is like, just kind of like the cartilaginous disc that is found in the jaw. This would be my patella. This would be the quadriceps tendon. So we talked about how that helps to stabilize the knee joints. And then we also have this one, which I think is the ligament. So this is the patellar ligament, because it connects the patella to the tibia. So the knee, if we look at the other diagram, has ligaments that help to stabilize it. And there's actually 4 sets of ligaments. And so these are called the collateral ligaments. They're collateral because they're on the outside. So what do you think the ligaments on the inside of the knee joint are called? So what is this one and this one called, do you think? What are they called collectively? They cross, and so they're called the cruciate ligaments. So this would be the medial collateral ligament, right? This would be the lateral collateral ligament. Right? So this would be the medial menisci. So the other one would be the lateral menisci. And so notice that they articulate and create a deeper depth of articulation because we have this articular cartilage in there. So this would be the lateral menisci. Okay, so the cruciate ligaments have an anterior and posterior, and it has to do with where they are on the tibia. So notice that one in the front that is coming from the back, but crossing over to the anterior part of the tibia. This is what is called the anterior cruciate ligament. This one would be the posterior cruciate ligament. Okay. Which one tends to be ripped more commonly in sports accidents? The anterior. So this would be the ACL. This is the PCL. So you talk about, I had an ACL tear. That's the anterior cruciate ligament. So you could write in that this is the tibia. Oh, sorry, this is the femur. And these are the condyles, right? So those condyles of the femur sit into the menisci. So we have a medial condyle and a lateral condyle. And then this would be the fibula. This would be the tibia. And you see that they've displaced the patella. So the patella actually forms within that ligament tissue and helps to protect the front of the knee. So it articulates not with the tibia, but actually with the femur. So I'll put patella, I'll put articulates with femur. So when you talk about the stability of the knee, for all that it has to do and all of the weight that it has to carry, right, it has lots of structures that help to stabilize it, right? So if I was going to ask, give me an example of a synovial joint and what are 3 factors that stabilize it, I would say, well, in the knee, I have 4 sets of ligaments. 2 collateral, 2 cruciate ligaments, that helps to stabilize it. The depth of the articulating surface is increased because of the presence of the menisci. And so that actually would help to stabilize it even more, right? And then the tension of the ligaments and the tendons that surround it, as well as the muscle tension. So for example, the tension exerted by the quadriceps muscle right here, right? If that is too loose, then this tendon becomes too loose, right? And then you could get that kneecap just floating on the surface of the knee. So some people's kneecap is so loose that they can actually touch it and they can actually move it around, right? That's not good for the stability of the knee, right? You want your kneecap to stay in place and help to support the knee. Okay, so we'll stop there for today. And we're gonna have one more day of skeletal anatomy in lab, and then your lab practical and your midterm are next week.